Good. So good afternoon, everyone, and welcome to the last series of the NCLEX review series. Our topic for today is ECG for the NCLEX. We're not going to learn how to interpret ECGs, but we're just going to visit some of the most important areas in the ECG that usually come out in the NCLEX examination. So one of them is going to be questions about electrophysiology. Electrophysiology explains how waveforms are created in the electrocardiogram and how electrical impulses are generated and spread throughout. So I have here a figure or a diagram of a heart, and I'm going to point out the most important areas of the electrical conduction system. So let's begin with the sinoatrial node. The sinoatrial node are specialized cells that are located in the right upper atria, and they're the ones that are responsible for initiating an electrical complex. And they usually have a potential, an ability of generating electrical impulses anywhere from 60 to 100 beats per minute. Now, if there's going to be a generation of an electrical impulse, the sinus node discharges them to the atria. And so once it goes into the atria, what's going to happen is it's going to depolarize the atria and cause a waveform known as the P wave. Now, the impulses further are going to go into a specialized area right over here. And this is what is known as the AV node. And the AV node is going to be an area which serves as a junction between the atria and the ventricles. And its physiologic purpose, actually, the reason why we have an AV node is in order to allow for complete atrial contraction before ventricular contraction. So let me explain what I'm talking about. When the sinus node fires and the atria contracts, the impulses do not go to the ventricles right away. And the reason is God created us to have two chambers or two pumps, the atrial pump and the ventricular pump. So therefore, it's important that the atria has to finish contracting fully before the ventricles do, because otherwise the contents of the atria will not go into the ventricles. So this is a very important part of the cardiac conduction system, the AV node's function. The AV node functions to delay electrical impulses to allow atrial contraction to occur before ventricular contraction. All right, I've written it because that's the most important physiological purpose of the AV node. So the AV node functions to delay electrical impulses to allow atrial contraction to occur before ventricular contraction. So as I said, the atria and the ventricles do not contract at the same time. The atria contracts, and then the ventricles has to relax, and afterwards, after it is filled, it's going to contract. And therefore, that's an important function of the AV node. Now, further, the impulses are going to have to go into the ventricles. And they do this by spreading the impulses to the right side of the heart, to the right ventricle, and then into the left side of the heart. And this is the function of the right and the left bundle branch. These are the areas that are going to depolarize or send the electrical impulse into the right ventricle and also into the left ventricle. And as you could see right over here, there are root-like structures that are going to penetrate the muscle mass. And these are what we call the Purkinje fibers. So the important parts of the cardiac conduction system are the SA node. They generate electrical impulses at around 60 to 100 beats per minute. Then it goes into the atria, then goes to the AV node. It's also known as the AV junction, where the impulses are going to be delayed to allow for full atrial contraction before ventricular contraction. And then it spreads into the right ventricle and the left ventricle to what we call the bundle branches, one called the right bundle branch, the other one called the left bundle. And in order to penetrate the thickness of the ventricles, there's going to be root-like structures or root-like connections of the bundle branches called the Purkinje fibers. So when we look at an electrocardiogram, we're going to see different waveforms. And so as a review, you can see the smallest waveform, and that is going to be the P wave. As you could see, this waveform is going to be smaller than the rest of the waveforms. And the P wave is a deflection that represents atrial depolarization. So that's very important. So when you see a P wave, then you know that the atria has depolarized, and depolarization leads to contraction. Okay, so what's the difference between depolarization and contraction? Depolarization is an electrical event. And this is going to be the one that is recorded in the electrocardiogram. Contraction is a mechanical event. Okay, just because you see waveforms in the electrocardiogram, for example, doesn't mean to say that the patient is alive. They could have normal waveforms, but they could be dead, right? So the P wave is the manifestation of atrial depolarization, followed by a series of waves. And because the ventricles are bigger than the atria, this is going to be inscribed as bigger waveforms, and they are called the QRS complex. So right over here, as you could see, is a series of waveforms, and they are called the QRS complex. QRS complex indicates that there's ventricular depolarization, which eventually would lead to ventricular contraction. This is when you would feel the pulse after the QRS has depolarized. Now, the relaxation phase of the ventricles. So when the ventricles contract, they must now open up to fill again with blood. And this process is going to be slow. So you see the last waveform is something that is slower. It occupies a greater geography in the electrocardiogram. And this is because ventricular repolarization is a slow process. Okay? Contraction is fast, but repolarization, or the resting phase of the ventricles, are going to be slower. And this is what is known as the T wave. T wave is a manifestation of ventricular repolarization, the time when the ventricles have to fill with blood again. Now, in some instances, there might be an extra waveform known as a U wave. This is going to be usually, if it's present, it's normal. If it's absent, it's also normal. So it could be present or absent, and it still could be normal. The only time that it would be significant is if it's going to be tall. So if it's going to be tall, it usually is a manifestation of an electrolyte abnormality. And that electrolyte abnormality is specifically hypokalemia. Okay, so we have talked about the waveforms, the different waveforms. So let's now take a look completely at an electrocardiographic pattern to point out the most important things. Whenever we start an electrocardiogram and find the 0 point, this is what is called the isoelectric line, or also the baseline. So this is where nothing occurs, or it's presumed that if there is electrical current that's happening, it is going to be a representation of a slow movement of electrical current. Okay, so a flat line in an electrocardiogram means two things. One, it's either going to be no electrical movement at all, or two, there's going to be electrical movement, but it's so slow that it becomes very negligible. Now, as you could see, the P wave always precedes the QRS complex, and the QRS complex is always followed by the T wave. Now, there are some times wherein waveforms are going up, meaning to say they're originating from the baseline and then going up. This is what we call a positive deflected waveform. Or it could be going down. And this is what is called a negative deflected waveform. And lastly, it could be going up and going down, and it is called a biphasic deflection. Now, some electrocardiograms are going to be seen as positive deflections. Some of them are going to be negative deflections or biphasic deflections. They do not necessarily represent an abnormality. It just depends on which area of the heart you're viewing it from, okay? So usually when you view it from here and the movement of electrical current is going like this, it's going to be a positive deflection. Or if your camera is here and the movement of electrical current is going away, it's going to be a negative deflection. Similar to a camera. So when you do an electrocardiogram, we have many views, and views in the electrocardiogram are leads. And that's why you've heard about 12-lead ECG or a 6-lead ECG. And what that means is that we have many areas of the electrocardiogram that we are mapping at, okay? So let's say that this was the heart, and usually the movement of the heart is from right to left. Your heart is from an orientation going towards the left side of your chest. So if I have a camera over here, this is my camera, and the movement of electrical current is going towards the camera, this explains why your waveforms sometimes are going to be upright. Similar to, let's say that you're taking a picture of your friend, and your friend is going to come towards you. This is your camera. The image that will result from the movement of your friend coming towards the camera will be that you will become bigger. Your face will become humongous. It would be big, right? So it's basically the same thing in an electrocardiogram. But sometimes the camera might be positioned over here. So if it's positioned over here, it's similar to your friend. You're taking a picture, but your friend is going away from the camera. What happens to the image of your friend? Does it become bigger or smaller?
Smaller.
Smaller. So similarly, in an electrocardiogram, if we're viewing it from this area, then it's going to be like this. Now, let's say that your friend, instead of going away, is going to go like this. So in the beginning, the friend is going to be big, and then it's going to be small, isn't it? Because it's going away from your camera. So it results in here in an electrocardiogram. If we're viewing it from here, then it's going to be something like this, okay? So that explains why this is a common question. Dr. Tom, why is it that when I see ECGs, sometimes they're going up and then sometimes they're going down? Well, it depends on the position of the camera. And the camera in an electrocardiogram is what is known as the lead. Okay? So usually we get a 12-lead ECG. That means to say that we're going to have 12 cameras that are going to be positioned around the heart, and therefore it depends on the position of that specific camera. Okay, so there are several waveforms of the electrocardiogram, and segments of it are going to be very important. One such segment is what is known as the ST segment. The ST segment is the connection between the QRS complex and the T wave. So this is a QRS complex, and this is a T wave. This connection right here is what is known as the ST segment. Now, why is that important? The ST segment is very, very important in order for us to diagnose the presence of ischemia as well as STEMI or ST elevation MI. So the ST segment offers us many information. So if it is depressed, that means to say that there's presence of ischemia. So I will explain what depressed is, all right? So usually when you have a QRS complex like this and the T wave like this, the ST segment is the same as the baseline right here, okay? That straight line. This is what's called a ST segment at the baseline. However, in some instances, what happens is if this is the QRS complex, the ST segment might be here, okay? So if you take a look at it right there, the ST segment is depressed. This is a sign of myocardial ischemia, okay? So ST depression, similar to this, is going to be a sign of myocardial ischemia. All right, the opposite is going to be something that is going to be very significant. Notice, this is the baseline, and if we draw a straight line, what happens to the ST segment? What do you notice the ST segment behavior is? Is it
elevated,
baseline, elevated, or depressed?
elevated,
It's elevated. ST elevation is a manifestation of STEMI, okay? So ST depression is a sign of ischemia, myocardial ischemia. So questions in the NCLEX might be, a patient is experiencing angina. You perform a 12-lead ECG. What will the nurse identify as an ECG change that would suggest the presence of myocardial ischemia? And the correct answer is ST depression. All right, patient comes in the emergency room complaining of chest pain. If the patient is having an MI, which finding are you most likely going to see? It's going to be an ST elevation. So I hope that you understand that, right? Okay, so in letter A, notice that the baseline is going to be at the baseline, meaning to say it's not depressed. Over here in letter B, what do you notice? What do you notice in letter B?
is an elevation,
Elevation. How about in letter C? What do you notice?
is a depression,
Depression. Okay. So what is this finding associated with as far as diagnosis is concerned?
An STEMI.
ST elevation MI. And over here, what would be your diagnosis?
Ischemia.
Ischemia. Okay. So it also is going to be a manifestation of non-STMI. All right. So which leads us to a discussion of what in the hell is this STEMI and non-STEMI? Okay. In STEMI, what happens is if this is the heart, why do we have a difference between these two types of MI? Okay. So let's say that this is the ventricle. There are some MIs wherein the damage is going to be from one wall and this is called the epicardium, and this is called the endocardium, the damage is going to be from one wall to another. It's called transmural because it affects the epicardium to the endocardium. This type of MI is going to cause ST elevation. Now, there are some MIs, infarction, wherein the damage is right over here, or it could be right over here, or it could be right over here. So they're partial thickness. They don't involve the whole wall of the ventricle. In this particular instance, there is going to be non-STEMI. So my question to you is, which one is more dangerous, the STEMI or non-STEMI? Which one has bigger damage?
The STEMI.
STEMI, okay. And that is why, ladies and gentlemen, that in STEMI, you are going to have to act within 60 minutes in order to either resolve the obstruction or maybe give streptokinase or something to dissolve the blood clot that is obstructing the circulation. Okay?
Yeah.
All right.
Okay.
So does that make sense now? All right. So in looking at STEMI right over here, do you see ST elevations? Hello?
Yes, I think so.
Okay, the ones that are highlighted are ST elevations. And this is an area that is going to be called the inferior portion of the ventricle. So we know that there is ST elevation, and therefore there's going to be a STEMI. Now, over here, what do you notice? There's no ST elevation. Look at the electrocardiogram. Do you see any ST elevations at all?
No.
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 No. Okay. Now, right over here, right over here, right over here, there's none. There might be this one, but it's only one. In order to diagnose MI in the ECG, you must have 2 or more ST elevated leads. Okay? So
Okay.
there's only one over here, and all the rest, and I'm going to help you out. This is depressed. This is
Yeah, that's
depressed.
depression.
This is okay. This is elevated, but it's only one. This is normal. This is normal. This is normal. This is depressed. This is
Yes.
depressed. This is depressed. This is depressed. Depressed. So we have a non-STEMI.
Yeah.
Okay. All right.
Professor, it doesn't matter which of the leads has, as far as 2 of them that has this
Correct. 2 connected
abnormality.
leads. Yeah, that's gonna be an advanced thing, but in general, in order to diagnose an MI based on an electrocardiogram, you must have 2 leads that are related. 2 leads that are related. Okay? All right.
Okay, thank you.
Great. Now, the other thing, okay, Dana, thank you very much for your feedback. Dana says, I never understood either. That was extremely helpful. All right, good. Now, there are also some electrocardiographic manifestations of an MI. We're talking about acute MIs, right? Now, is it possible to diagnose an old myocardial infarction? And the answer to that is yes.
Yes.
How do we do that? Well, you remember that if you have an MI, it eventually heals and it will have a scar tissue. How do we detect a scar tissue in the electrocardiogram? Well, we can detect that because the detection is going to be the presence of a pathologic Q wave, an abnormal Q wave. So there are many definitions of abnormal Q wave. I don't want you to memorize them, But in NCLEX, previous exam questions had only said what would be the manifestation of an old MI. And the answer to that would be a pathologic QA, okay? An abnormal QA. So if you notice over here in this electrocardiogram, you have a P wave, a QRS, and a T wave. The Q waves are very small. But in a patient with a myocardial infarction, look at this Q wave. They are so deep, they're so big, and therefore this is what is known as a pathologic Q wave. And this is an evidence of an old MI. Okay? All right. So ST elevation is going to be a manifestation of STEMI. ST depression could be a manifestation of ischemia or non-STEMI. Okay. So I would like to further now differentiate the difference between STEMI and non-STEMI. Now, both of these is going to cause the signs and symptoms of an MI, namely chest pain for both of them. Okay. Now, however, in STEMI, what's going to happen is that the ECG is going to show ST elevation in 2 or more leads. In non-STEMI, ECG shows ST depression. For both of them, you're going to have to do a laboratory test, and that laboratory test is going to be troponin, right? So when we do a troponin, in non-STEMI, they're going to be positive. In STEMI, they're also going to be positive. That means to say that there is a damage of myocardial tissue. All right. If the chest pain is going to be associated with a negative troponin, then that means to say that this is what is known as unstable angina. All right. So the presence of a positive troponin is an indication that there has been death of cardiac tissue. So it could either be STEMI or non-STEMI. The absence, however, of cardiac troponin indicates that there is no permanent damage that happened in the heart. And therefore, this is a manifestation of your unstable angina. Okay, so let's go to the first question. Please just answer using the chat box. Okay, your answers? Very good. The answer is letter C, because it says that the patient has a myocardial infarction. Very good. Next. Very good. The correct answer is letter A. Okay, so we're looking for the QT interval. Now, this is the baseline. This is the P wave. This is the Q wave right here. The R wave, the S wave, so that's the QRS complex, and the T wave. From the beginning of the Q to the end of the T wave is what is known as the QT interval. Now, over in letter B, this is what is known as a P wave. In letter C, this is known as the ST segment. And letter D is what is known as the QRS complex. Okay? Next.
Oh, this one's tricky.
Okay. So it's the same thing. You already know that. Which highlights the ECG that may be elevated above the baseline, indicating STEMI. You remember STEMI? What does it stand for?
ST, elevated MI.
Okay. So from the very term, which one should be elevated? A, B, or C? You remember A is QT, B
C?
is the P wave,
Yeah.
D is what?
The
D
U.
is
U
U
wave
wave. Okay,
U wave.
very good. And the C?
is a
ST. Ah, okay.
Ah.
Yes. I see. I think I was going off of the isometric line. Like I was trying to.
Isoelectric line, yeah.
Yeah.
Okay,
Yeah,
so
it's
that's where the ST segment is, the connection between the S wave and the T wave, or the QRS complex and the T wave. Okay? All right. So let's move on. Whenever we're looking at an electrocardiogram, it is a graph. And like any graph, we need to understand it in order to be able to interpret any waveforms that are going to be inscribed at it. So here is an enlarged view of this particular segment right over here. And in order to interpret electrocardiograms, we're going to examine the timing of these waveforms. And it also is going to be very important to examine how much voltage or how much electricity is generated by these waveforms. And so if a waveform is going to be inscribed in this graph, we're able to now interpret voltage as well as timing. So if you can see over here, we enlarge a box, a big box. Each box also is going to have 5 small boxes. One large box contains 5 small boxes. And each box, if we enlarge this, is going to represent 1 millimeter going up and down, or horizontally, it's going to be a time interpretation of 0.04 seconds. So what does that mean? If I have a waveform that is going to be this tall, how much voltage do we have? How many millimeters is this? How many
10.
boxes?
2. So
2.
it would be 10.
Okay. So 2 is equal to 0.2 millivolts. All right? Now, let's say that I have a waveform that starts over here and ends over here. How many seconds is it? How many seconds is this? Remember, each box is equal to 0.04. So 1, 2, 3, 4, 0.04 times 4 is equal to 0.16 seconds. Very good. Okay. So you understand that? All right, that's all we're going to talk about the electrocardiographic graph paper. Okay, what it means. All right, so each small square is equal to 1 millimeter or 0.1 millivolt. Each millimeter represents 0.04 seconds of time interval. Clear? All right. Let's go now to calculating heart rate. There are many ways to calculate rate in an electrocardiogram, but in the NCLEX, you don't have time to do anything else other than to do one method of calculation. And so when you're looking at an electrocardiogram, you're going to notice that on top or at the bottom of the paper is going to be a straight vertical line right over here. All right. Each vertical line is actually going to represent 3 seconds. So this is also 3 seconds and so on. Now, let me ask you a question. If you take a pulse rate for 30 seconds, what are you going to, let's say that in 30 seconds you obtain a pulse rate of 40. What is the minute heart rate? You took the pulse of a patient.
80.
Okay. And you counted 40 in 30 seconds. What is the minute heart rate?
80.
Well, 80 is going to be the heart rate. Why? You multiplied 40 times 2, correct? Because you only used 30 seconds. How about if you only counted the pulse for 6 seconds? What must you do in order to record the minute heart rate? You only counted for 6 seconds. What would you do?
Multiply by 10.
Multiply by 10. Okay, very good. So, therefore, the easy way in NCLEX is to look at the electrocardiographic paper, and they usually are going to give you 6 seconds of a strip. You count the number of complexes in that strip, and that would be your 6-second rate. You multiply it by 10, and that would be your minute heart rate. So in this example, what would be our minute heart rate?
$50?
No.
Wait.
How many complexes do you see?
1, 2, 3, 4, 5, 6, 7, 8, 9, 9.
Oh. Now, see, this is outside of the line already. You should not count this already because this, you're only timing it for 6 seconds. So you say 1, 2, 3, 4, 5, 6, 7, 8 times 10. Okay, that would be 80. All right, let's go to another thing. Okay, over here, what is your heart rate?
Very, very fast. You actually really can't count this one because you can't determine if there's a distinct P wave before
Here's
each.
the distance right here. It's 6 seconds. It's from here and it ends right over here.
Yeah, it
Oh,
looks
you
like
have
190.
190.
90.
very good, very good. 190. That is excellent. Great. Okay, let's see. I want to make sure that you understood it. All right. Could you please tell me, in this particular paper, they do it 1 second each. You see this line? From here to here is 1 second, here to here is 1 second. 1 second, and so on. So it's 1, 2, 3, 4, 5, 6. Okay, so this is a 6-second strip. Now, tell me what the heart rate is.
200. Yeah, 200. I counted 20.
Is it 20? How about the others? 1, 2, 3, 4, 5, 6,
Yeah, it's
7,
20.
8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 9. Hot dog. Yeah, it's
Hot dog.
200.
Hot dog.
200. Oh my God, that is going to be fast.
So
Okay.
it's like
Yeah,
SVT with
definitely.
every
Okay. So I want you to calculate the heart rate over here.
2, 3, 4, 5, 6. I got 60. But Professor,
No, it's not 60. Before you ask your question, think
No.
think again.
100 because it's only 5, I think.
Yeah, because this other one, the last one right here,
It's
you're not going to
out.
count it. Why? It's
Yeah.
already outside of the line. You're only
That's
going
also-
to measure the 6 second.
okay. Because that's the
Okay.
funny part. Well, okay, so always that line, that last line, if it's outside of that word, like that line, do
Before
not
and
count it.
after.
Okay.
Before and after. Okay. So let me give you another example. Right here. Okay. How about this? What's the heart rate?
$40.
40. Okay, very good. How about here?
70.
70. Very good. How about here?
Oh my
40.
God, 30?
No,
30.
it's only
40.
30. You're not
Yeah.
going to count this because it's outside of the line.
Oh, the trick. Oh, okay.
Yes,
Okay.
okay. So this is outside of the line and this is outside of the line. You only count those things that are within the line. So this is 1, 2, 3. Okay, one more.
Okay. 1, 2, 3, 4. 40.
40. Very good. Okay, so you know, for the purpose of NCLEX, a rapid way to calculate heart rate is to look at the 6-second mark and then multiply it by 10. Okay. So anytime you have a heart rate of more than 100, it is called tachycardia. If it is less than 60, then it's going to be called bradycardia. Regardless of what rhythm, tachycardia or bradycardia, they're going to be distinct as far as management is concerned. So any tachycardia is going to be a manifestation that there's going to be a decrease in cardiac output. Because when your heart rate is too fast, the heart will not be able to fill. And therefore, the treatment for tachycardia is usually to treat the cause, because usually it's a compensatory mechanism. Or tachycardias could also be managed by vagal maneuvers. So when we talk about vagal maneuvers, we're talking about stimulating the vagus nerve. And there are several ways to stimulate the vagus nerve. Okay? So one such vagal maneuver that is going to slow down the heart rate is going to be what's called Valsalva maneuver. Valsalva maneuver is what you tell patients who are laboring and having contractions. If you want them to deliver the head, you're going to ask them to push as hard as they can. It's exhalation against a closed glottis. Or if you are constipated, that's what you usually do in order to deliver your feces. So that's Valsalva maneuver. Valsalva maneuver is effective in slowing down heart rate. Now, another thing is that just merely holding your breath is going to be a form of Valsalva maneuver. So when you are underwater, do you breathe? No. Or if you hold your breath, what's going to happen? You're going to slow down the heart rate. So you can do this experiment when you are in the area, clinical area, and you have a, let's say, electrocardiogram, connect yourself, and you're going to hold your breath. You will see that your heart rate is going to gradually decrease. The other thing that we could do as far as vagal maneuvers in children is actually to have a cold face cloth over the face. And this is particularly effective in children. Now, when you shower and you take the first drop of water hitting you and it's cold, what do?
You hold your breath.
Yeah, you do this, right?
Yeah.
So basically, you're doing vagal maneuver. And therefore, this is very effective in children. Now, in adults, we don't do that. In the emergency room, we rather just fill a basin of water and ask an adult to go to dunk their face underwater because sometimes they can't hold their breath. Just merely instructing them to say, hold your breath, they can't do it because they're panicking. So if you put a basin full of water and you dunk the patient's face underwater, they're going to hold their breath. And this is a form of vagal maneuver that could actually stop or slow down the heart rate. Now, another way in which we could do this is what is known as the carotid sinus massage. Now, carotid sinus massage is a procedure that's only done by trained personnel. And the procedure is at the angle of the jaw right here. So I'm going to illustrate that. So if this is your neck, you have your carotid arteries right over here, okay? Now there are specialized bodies right over here known as baroreceptors or pressoreceptors, meaning to say that they are very sensitive to pressure. So actually, God created this so that when there's a lot of volume of blood going into the brain, it actually is going to signal the vagus nerve that there's too much circulation of blood into the brain. It might rupture it. So the body now compensates by decreasing the heart rate to the vagus nerve. The vagus nerve is activated. It commands the heart to slow down, chill, cool. Okay? So when we massage this area of the neck, we are actually basically then mimicking that there's a lot of pressure going into the brain. So when you massage the neck right here, what's going to happen is that there's going to be a communication to the vagus nerve, and the vagus nerve in turn will command the heart to slow down. This is what is known as carotid sinus massage. The reason why nurses are not allowed to do this without proper training is because you could cause a CVA if the patient already has a carotid stenosis. And therefore, before the procedure, it is imperative that the one that does the carotid sinus massage must listen to the carotid arteries for the presence of a bruit. A bruit is a sound that sounds like psh, 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 a movement of blood through a narrow opening. That is what is known as a bruit. So in that case, if there's a carotid bruit, they will never do the carotid sinus massage. Now, another thing that actually activates the vagus nerve is when you have a headache, what do you usually do to relieve it? One way to relieve a headache, I don't know about you, but for me, when I have a headache, sometimes I press on my eyeballs, and that usually is going to temporarily ease the headache. And so orbital pressure is the same thing as what I have explained to you. What happens is when you press on your eyeballs, what happens is there's going to be a detection of an increased intraocular pressure. This in turn will stimulate the vagus nerve, and the vagus nerve will now command the heart to chill, slow down. Okay? So those are the vagal maneuvers that are effective in the management of tachycardia. So before we go to drugs, before we go to electrical interventions, we like to try this first to terminate the tachycardia because they're non-invasive. Now, the next thing that we're going to do, if that doesn't work, particularly if the patient is going to be symptomatic and they're gradually declining as far as cardiac output is concerned, is that we might have to institute, drug therapy. And what are the drug therapies that might be included in the management of tachycardia? One such thing is what is called adenosine. And adenosine is a very specialized drug, and this is usually given very quickly because it has a very short half-life. So usually adenosine is going to be given with special precautions. So when you give adenosine, there are several things that you must do. It must be given rapidly. It must be followed by a 20 cc's normal saline flush. You also should elevate the limb where the IV is. In India, I practiced in India for 3 years. I taught in India for 3 years. But part of the protocol for administering adenosine was always put the patient on Trendelenburg position. And that is very, very wise procedure. We don't do that here in the United States. But the reason why we do that in India is because when you do Trendelenburg, you're now going to facilitate the entry or the effect of the drug directly into the heart. Okay? So those are the important things. And the other thing that you must know is that it will cause a brief period of asystole. And the patient will feel this. And sometimes they will also feel a flushing sensation while you're giving the adenosine. Okay? So I don't know if you've ever seen or you yourself administered adenosine, but adenosine is a very, very effective drug in terminating supraventricular tachycardias, which we will talk about in a little bit. Okay? Now, the other drugs that we could give are beta blockers, like sotalol, for example. So remember that anything that ends with an ol is going to be a beta blocker. Alol happens to be both a beta and alpha and a beta blocker, beta 1 and beta 2 blocker. All right, calcium channel blockers could also be given. So drugs that are going to be effective here are going to be like cardizem. The other thing is procainamide, and lastly, amiodarone. So these drugs, adenosine, beta blockers, calcium channel blockers, procainamide, and amiodarone could be instituted in order to slow down the heart rate. And lastly, if you're not going to respond to any of these, we might as well give you a zap. And the zap that I'm talking about is what is known as cardioversion. And there's a difference between cardioversion and defibrillation, which we will be discussing in a little bit. So cardioversion is going to be done But the one thing that I want to tell you about the difference between cardioversion and defibrillation is one important thing. Cardioversion is always delivered to patients who are alive. If a patient is clinically dead, we defibrillate them. Do you understand? So if I don't have a pulse, what do you give? Defibrillation or cardioversion?
Defib.
Defib, because you don't have a pulse, you're dead. Okay. Now I'm saying, oh, nurse, help me, help me. Defibrillation or cardioversion?
Cardiover.
Cardioversion, the patient is alive, right? Or the patient has a blood pressure of 80 systolic, palpable. Defibrillation or cardioversion?
Cardioversion.
You won't have a blood pressure if you're dead,
Right, right.
So that's an easy way to distinguish the two. But we'll talk more about that in a little bit. Okay? So any fast rate is always going to have these interventions. Let's now go to the opposite, and that is bradycardia. Bradycardia is any heart rate that's less than 60. So usually there are instances, let me tell you what my pulse rate is now. Hot dog. My pulse rate is 52. Should you treat me?
You don't have any symptoms.
Okay.
Yeah.
And I am poor. I don't have cash.
Oh.
You only treat patients with bradycardia if they have a lot of money, meaning cash. Cash actually is an acronym that tells you if a patient needs treatment or is symptomatic. Cash stands for chest pain. So I normally have bradycardia, but let's say I have a pulse rate of 52 and I'm having chest pain. That indicates that I need to be treated. I'm not tolerating that slow heart rate. The other one is if I tell you Paris is beautiful and dead. Now, did that make sense to you? I'm in the middle of lecturing about electrocardiography, and I'm talking about Paris and dead. There's
Yeah,
an altered mental status. So
Yeah,
you
that
need
makes
to
sense.
treat me, right? So altered mental status is an indication that a person is rich, and therefore we need to treat them. The other thing is symptoms of shock. S is shock and also shortness of breath. Not son of a bitch, shortness of breath. So if a patient is full, clammy, blood pressure is low, then that is an indication that there's a severe compromise of cardiac output. And the last one is either hyper or hypotension. So a blood pressure of 200 or a blood pressure of 60 are both manifestations of a decrease in cardiac output, and therefore they need to be treated. So whenever there is bradycardia, the first intervention that you always have to do is to always assess for cash for signs and symptoms of altered cardiac output. All right, so the treatment would include atropine 1 milligram or dopamine at 5 to 20 micrograms per minute or epinephrine. And of course, if these did not work, we could now have an external pacemaker applied and therefore are going to externally pace the patient. So these are the treatments for bradycardia. Okay, so now that we have talked about the treatment of tachycardia and bradycardia, we're now going to talk on specific electrocardiographic patterns that have relevance in the NCLEX. Remember, I'm not teaching you how to interpret it here. I'm just telling you the points that are important for the NCLEX. But it's now 2:29, so let's go ahead and take a 5-minute break. And then when we return, we're going to talk about important ECG rhythms that you need to know for the NCLEX. 5 minutes. Okay, I hope you're all back. Let's go ahead and continue. Uh, hmm, with our discussion. Let me just make sure that it's recording. Okay. So the next thing that we're going to talk about are specific rhythms And let's take a look at normal sinus rhythm. Normal sinus rhythm is the normal, so it doesn't need any treatment. And always begin by counting the rate. The rate will actually clue you to whether or not it is normal or it needs intervention. So if you take a look at over here, what is our heart rate? 1, 2, 3, 4, 5, 6, 7, 8, 80. And so it's between 60 to 100. We don't need anything. Okay? So that would be the important thing. Now, let's say that there's going to be a slow heart rate. Let's say it's 40 and the patient is having CASH, meaning to say chest pain, altered mental status, shock, shortness of breath, hypo, and hypertension. So what is the treatment? Well, if they're symptomatic and they have CASH, we would give oxygen. We could give atropine 1 milligram. If unsuccessful, we're going to have to do an external pacemaker. And here is an external pacemaker. For those of you who are not familiar, we're going to, similar to what you do when you defibrillate or cardiovert the patient, they connect the patient as pictured over here, one on the right shoulder area, and the other one on the left apical area. So we're going to stimulate the heart by delivering electrical stimulation or energy through the chest. This is what is known as transcutaneous pacing. Okay, so we've talked about tachycardia. So if a patient is having tachycardia, then what we need to do is to make sure that we treat the cause. But there are some tachycardias wherein it is going to make the cardiac output decrease, and so the patient will most likely have CASH. So if you take a look at this particular slide, what do we see over here? A rapid heart rate, very, very fast. So I think we counted this earlier and it was 190. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. Yes, 190. And obviously, nobody can tolerate a heart rate of 190. So this is going to be what is known as supraventricular tachycardia. And the reason we call it supraventricular tachycardia is because the QRS is narrow. It's not wide, and therefore we assume that it's coming from above the ventricles. Supra means above, ventricles meaning to say that this rhythm originates from above the ventricles. So it could either be from the AV node, the atria, and so on. It could not be from the sinus node because the sinus node can only fire up to 140 beats per minute. And so when this happens, when you have paroxysmal atrial tachycardia, what we're going to do is to do vagal maneuvers first. So you remember those vagal maneuvers that we had talked about. Can you give me one?
Like hold your breath.
Hold your breath. Okay, what else?
Bearing down.
Bearing down. What else?
Oh, the cold plunge.
Yes, in children,
For the
right?
kids, yeah.
What else?
The bucket of water for the adult.
Yes, very good. Okay, so we can do vagal maneuvers first, and if they're not effective and the patient is now deteriorating, what we could do is if we have time, we're going to give your drugs, adenosine, diltiazem, beta blocker. If nothing else works, then, or if the patient is unstable, then that means to say that we need to act fast, and therefore we would cardiovert. So I promise you that we will be discussing what cardioversion is. And so let's go ahead and do that. Now, the difference between cardioversion and defibrillation are going to be many. And in fact, this is one item in the NCLEX that is usually present? Okay, so we do this for patients who are dead, right? This is for alive. So you know what the definition of alive is. That means to say they have a blood pressure, they have a pulse, they're breathing, and so on. Now, the other thing is that in cardioversion, this is going to be a synchronized event. Now, what does synchronized mean to you? Have you ever watched Olympics and synchronized swimming, for example? What does synchronized mean to you?
Formation, like getting everyone in one formation
Okay, at the same time.
at the same time, yes.
Yes, that's the most important thing. Okay, so in the electrocardiogram, I'm going to draw the waveforms of an electrocardiogram. This is a P wave, Q, R, S, and then a T wave. Now, whenever we have an electrical impulse occurring at the vulnerable period, meaning to say at the special area of the electrocardiogram, it will cause cardiac arrest. Now, supposing, why is it that some people get electrocuted and they are going to be okay? Nothing happens to them except for the fact that they're just going to be shocked, right? But there are some people who are exposed to electricity and they die. Why? Well, what happened? What's the difference? Okay. Well, see, if an electrical current occurs right over in the vulnerable period of the electrocardiogram, right in this area of the electrocardiogram, it is going to cause the patient to die because they're going to fibrillate. Now, let's say that you touch an electrical current and it happens right here. Nothing will happen to you, okay? So when we are introducing or using an electrical current to convert a fast rhythm, what we want to make sure is we want to avoid this area. And so we tell the machine, please only deliver the electrical current right over here. We don't want it anywhere else. We want you to deliver over here. The machine is so wise and says, okay, I will tell you or I will show you where I will deliver the electrical current so you will know. So what do you mean? I will tell you. The machine is telling you, I will tell you. This is exactly what you see right over here. You see an electrocardiogram over here with white dots. Do you see the white dots? Hello?
Yes, yes, we see it.
Okay.
Yes.
So these white dots are these ones right here. Okay. So the machine is saying, okay, I synced it. This sync right over here, it says, I time it. I am going to time the delivery of the electrical current right on the dots. Do you want it there? And so if you say yes, then that means to say you can proceed with the cardioversion or the delivery of the electrical current. Oh, stop it. All right, so do you understand what I mean? That the machine will mark where it's going to deliver it. And so therefore, and I lost the difference between cardioversion and defibrillation. So it's synchronized. It is going to time the delivery of the electrical current right on the downslope of the QRS complex. So electricity is going to be delivered at the downslope of the R wave. That is cardioversion. Now, in defibrillation, the patient is dead. Does it matter where it touches or where
No.
it hits? No.
I don't think it matters. No.
So this would be unsynchronized.
Mm.
Synchronized.
Finally,
right.
I understand what synchronized and unsynchronized is.
Huh? Okay.
Finally,
So
we understand.
let's say every time I clap, you need to clap too. Clap and you clap too. That means to say we're synchronized. We're at the same time. Okay. Now, when the electrical energy over here, it keeps on disappearing. All right. Okay. So again, if these are the waves of the electrocardiogram, okay. Now, when we synchronize, we said we're going to time it. What are we timing it with? Okay. We want the delivery of that electrical current in a special area of the electrocardiogram. And it is right here. See this? The downslope of the R wave. This is the upslope. This is the downslope. So we want the electrical current to be delivered over here, not over here, not over here, not over here, not over here. The reason is if we do not synchronize it, it might deliver it over here. And if it delivers over here, the patient who is alive becomes dead. So do you understand? We want to time it right over here. Okay, so that's what's called synchronize. And the machine will tell you, this is where I'm synchronizing it. I am delivering the electrical. See the, oh my God. See where the dots are? It says, okay, this is where I sync it. Do you want it here? And if you do, then you just go ahead and push the button to deliver the electrical current. Is this the right spot? And the answer to that is yes, because as we said, it should be delivered at the downslope of the R wave. Okay? So in defibrillation, cardioversion, defibrillation, this is going to be synchronized. And of course, over on the other side, it's not synchronized. It's delivered anytime where it wants to deliver. Now, the other thing is the patient is alive in cardioversion, right? And dead in defibrillation. Now, delivery of electrical current is painful. Have you ever seen somebody being cardioverted or defibrillated? It's going to cause some pain because electrical current is going to hit you. It's almost like hitting the chest physically. Actually, when you hit the chest right here, it actually delivers around 50 joules, similar to what is happening when you deliver an electrical shock. All right. So do you want to give a big dose or a small dose if a patient is alive?
Small.
Small dose.
Small dose, okay. So usually when we give a cardioversion, we use anywhere from 50 to 150 joules. So we usually start low. But in patients who are defibrillated, we max it out. And maximum could be 200 joules or 360 joules, depending on the type of defibrillator that we have. Okay? So if the patient is dead, we go all the way out and deliver as strong an electrical current as possible in order to simulate the heart. So those are the difference between cardioversion and defibrillation. And so sometimes, depending on the situation, if the patient is not shocky, what we could do is maybe we could actually give sedation or mild sedation to these patients. Do you sedate a dead patient? A dead person?
No.
You're just wasting the drug, right? So there's no sedation in defibrillation. Okay. Those are the differences between defibrillation and cardioversion. Okay. So these are the difference in summary. Cardioversion is going to be either pharmacologic or electric. The reason there's a pharmacologic over here is, if you remember adenosine, adenosine is one type of cardioversion actually, okay? So what we just talked about is electrical cardioversion. It's synchronized anywhere from 100 to 150 joules, I'm sorry, on live patients. And these usually are the rhythms that are cardioverted. You don't need to remember these. But defibrillation might include the application of an AED. It's an unsynchronized. We could give as much as 200 to 300 joules on dead patients, and therefore this would include these particular arrhythmias. Okay. All right, I have a question here, but I don't want you to answer the question as it is. What I wanted to illustrate over here is this is a tachycardia. So what did we say the heart rate was earlier? It's what is the heart rate? Tell me the heart rate.
1, 2, 3,
200.
200?
200, yes.
Okay.
Yeah.
All right. So would digitalis work for this patient? Would digitalis work for this patient? What is the action of digitalis? Slows down heart rate. It's a negative chronotropic agent. So yes. How about labetalol? What is alol?
That's good
A
too.
beta blocker.
Beta
Yes.
blocker?
Beta
Okay,
blocker.
yes. Dopamine will help?
No.
No. What does dopamine do? You remember dopamine is a
For
type
bradding.
of epinephrine. It's a sympathomimetic, and therefore it would increase heart rate even more. How about epinephrine?
No.
No,
Okay,
that's
it will make it
increasing.
worse.
Yeah.
How about cardioversion?
Yes.
Yes.
Yeah.
How about exercise?
No.
No, right now.
Immersing the patient's face in a basin of water.
Yes.
Could be.
Yes.
My work.
Very good. It might work. Okay. In fact, we should start with that one, right? Okay. So let's now go to a special arrhythmia known as atrial flutter. Now, if you see over here, it looks like there is a sawtooth right over here. Do you know what a sawtooth is? Okay. So if you are cutting wood, there might be an implement that's going to be like this. That's the saw that we're talking about. So notice this electrocardiogram. In looking at it, it looks like there is jaws or a sawtooth pattern. This is what is known as atrial flutter. And this represents that the atria is contracting or depolarizing at a very rapid rate. So instead of the atria doing like this, in flutter, it's going like this. So it is fast. So if it's fast, is it contracting? Look at my hand. Will I be able to eject blood if I do this?
No.
No, okay. So the implication of this rhythm is that the atria is not contracting well, and therefore it could cause a physiologic effect on the individual. And we'll learn more about what the effects are. Now, it is a relative to another rhythm called atrial fibrillation, which is even faster. I said atrial flutter was like this. Atrial fibrillation is like this. So it is going to show you, notice again, over here, the undulations, like small sawtooth right here. Big teeth is atrial flutter, small teeth is atrial fib. And it's going to cause a very irregular rhythm. Again, these two are relatives. And so the primary consideration, whenever there is going to be a lack of contraction in the atria, are several things. But one very important thing is that it could cause a CVA. Now, if this is the right side of the heart, right atrium, right ventricle, lungs, left atrium, and left ventricle. Okay. So what's the first branch of the left ventricle? The aorta. And the first branch of the aorta is all actually the carotid arteries. Okay? All right. So when the atria is fibrillating or having a very fast rate, what's going to happen? I said that there's a risk for a CVA. Why is that? Because whenever you're not moving blood, because it's merely shaking, what's going to happen? Blood will aggregate and therefore form blood clots. Now, the blood clot is going to form where? Is it the right side, right atrium, or is it in the left atrium?
I think it's on the right.
The right atrium.
Okay. No, the correct answer is the left atrium. Because if it's going to form in the right atrium, it actually is going to cause pulmonary emboli. Understand why it would cause a pulmonary emboli? Because blood clot is going to form over here. It travels to the right ventricle, and therefore it lodges in the lungs. But I told you that it causes a CVA. Now, the reason why it causes a CVA is because the left atrium actually is going to have an anatomical part called a left atrial appendage, like an appendix. So this appendix right over here, if blood is not circulating well, it's going to stagnate over in this area because it's a small area. So therefore, the result is if it occurs on the left atrium, it's going to travel to the left ventricle, travel to the aorta, and voila, it travels into the brain. So that's the reason why you would have a CVA whenever you had atrial flutter or atrial fibrillation. Okay? So do you understand? That's a very, very important question in the NCLEX. The stagnation of blood in the atria is usually going to cause A, pulmonary emboli, B, peripheral emboli, C, CVA. What would be the correct answer? The correct answer is a CVA. For the specific reason that the left atrium has an atrial appendage, which most likely will be the site of where blood clots can form. Okay? So therefore, if that is the case, what do the treatment of atrial fibrillation and atrial flutter include? Well, it will include measures to control the heart rate, but it also includes measures to prevent CVA from happening. So anticoagulation is important. Question: a patient develops atrial fibrillation all of a sudden. What would be your intervention? A, report to the charge nurse. B, note the incidence and note its progression. C, call the physician right away. The correct answer to that is call the physician right away. The reason is, if the patient develops a stroke because you did not pay attention, then you could be a respondent to a suit. Okay? So it's important that we prevent that complication whenever we see atrial flutter or atrial fibrillation, because anticoagulation is necessary in order to control the possibility of a CVA. Diltiazem or beta blockers are usually given in order to control ventricular heart rate, or it could also be that we can have cardioversion as an option if the patient is going to be symptomatic. So that's all I want to tell you about atrial fibrillation. Now, whenever you are taking care of a patient with atrial fib, that would mean to say, no, shut up, Tom. Let me just do this first, and then we will talk about it. You remember it's not tachycardia for the heart rate. The heart rate is still going to be normal. So this would not be an option. We're only going to do this if there is going to be your heart rate is going to be over 100. And notice over here, is your rate over 100?
No.
The other one, is your rate over 100? No. The
No.
atria is the one that's having the quivering. It's not the ventricles, okay? So therefore, that would not be a correct answer. All right. So should we give atropine? What does atropine do to heart rate?
It increases it.
It increases. It's to treat bradycardia, right? So
Yeah.
this would be incorrect, all right? How about assess for an apical radial pulse deficit? All right, what is in the hell is this? Okay, so if you're examining a patient and you are now using a stethoscope to listen to the patient's chest and at the same time feeling the pulse, you are now assessing whether all the heart sounds are causing a pulse. So normally when you hear something like lub-dub, there should be a pulse, correct? Yes or no?
Yes.
Yes. However, in atrial fibrillation, not all sounds that you hear will cause a pulse. So you might be hearing, but the pulse is only once in a while. So there's an apical radial pulse deficit, the difference between the two. You might have heard 100, but you only felt 60 as the pulse. This is what's called an apical radial pulse deficit. The greater the deficit, the more serious the situation is going to be because you are not producing enough to cause a cardiac output. Okay, so letter B is a correct response. Now, why is letter A incorrect? Anybody can tell me why letter A is incorrect?
Because of the apical pulse is not found on the left side, it's on the right side of the wait.
No, it's good.
Oh.
Isn't the left side is good?
Yeah, the left side is good, but where should you examine the heart from? If you're the examiner,
in front
when
of
you're
them.
doing physical assessment and examining the heart, where should you be at? It's a
In front
very
of them?
important concept. It should be on the right side. The reason why you should be on the right side is so that you could see any pulsations that might be occurring on the left side. Okay? So when you palpate also, what's going to happen is that you would need to follow the direction of the heart. So to determine the PMI, or the point of maximal impulse, remember you need to put your hands over the precordium and feel where the pulsation is going to be, and that's where the PMI is. So letter A is incorrect because you should examine the patient pulse, apical pulse, from the right side. All right? Tricky, tricky, tricky. Is that clear?
A little bit, yes.
Okay.
Yeah,
So always
can you
remember
explain
that physical examination, you examine the heart from the right side of the chest. Always. Never from the left. Okay. All right. So there are situations wherein you will see P waves that are divorced, meaning to say that they do not have a QRS complex. So notice this, P wave married to a QRS, that's okay. P wave that does not have a partner.
Yeah.
Whenever you see P waves that do not have partners, that means to say that there's a condition known as AV block. AV block. And there are several types of AV blocks, but nonetheless, this is just a quick way to identify an AV block. Notice this ECG. Are all your P waves having a partner? Okay.
No.
So let me help you. P, QRS, T wave. 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 P, pa, pa, pa. Does it have a partner?
No partner.
What is our diagnosis?
AV
So
block.
it's IV block.
AV block. Very good. Okay, next. We're going to look at this. Is there a problem?
Yeah.
Yes, okay. So
Prolonged.
PQRST, P,
No partner.
Not married.
PQRSTP, no partner.
No partner.
We have an AV block. Okay, over here.
Yeah, also no partner.
No partner. See these P waves right over here? They do not
Yes.
have partners. So we have an AV block. So what do we do when there is an AV block? Well, there are several things that we can do, but what we can do actually is prepare the patient for pacemaker. All right. So AV blocks will be treated with a pacemaker. All right. So that is going to be a universal statement for the treatment of AV block. Now, remember that there are different kinds of AV blocks, but nonetheless, as a general rule, when you see AV blocks, the treatment is going to be the insertion of the pacemaker. All right. Question. Very good. It would be letter D, ventricular depolarization. Okay, ventricular repolarization would be the T wave. Atrial depolarization would be the P wave. We usually don't see atrial repolarization because it's going to be buried by other waves because the atria is so small, and as it's relaxing, the ventricles are contracting, and therefore we don't see atrial repolarization. Okay, just wanted to show you this film, showing you how pacing is done.
Place the defibrillator pads on the right chest wall and lower left chest wall as indicated on the pads. Ensure that the pads are connected to the defibrillator. Turn the defibrillator dial to pacer or press the on button if available. Capture the heart rate. If the patient is in cardiac arrest with bradycardia or an asystolic rhythm, the pacing should be initiated at the maximum current output to ensure that capture is achieved as soon as possible. After which time, the current can be gradually reduced to 5 to 10 milliamps above the threshold for capture. The presence of a wide QRS complex after each pacing stimulus suggests but does not confirm the capture. Cardiac capture should be confirmed by assessing the pulse, blood pressure, and clinical status of the patient.
Okay, so we're done with that. Let's go ahead and talk about ventricular rhythms. If there is any rhythm in electrocardiography that needs special attention or immediate attention, they are the rhythms that originate from the ventricles. So it is important to recognize ventricular rhythms. How do we know that rhythms originate from the ventricles and not from the sinus or the atria, which is going to have a great physiological effect? Well, we know that an impulse, I should say, originates from the ventricles because they have the following characteristic. One is that they have a wide QRS complex. Now, a normal QRS should be less than 0.12 seconds in duration, or if we transmit that into number of boxes, it should be less than 3 small boxes. You remember those boxes that I told you about earlier?
Yes.
Yes.
And then the other thing is we have what's called PAR-DT. Now, normally, we have, if the QRS complex is going up, the T wave also goes up. If the QRS complex goes down, the T wave also goes down. And if the QRS complex is biphasic, meaning to say it goes up and down, it also goes, the T wave also goes up and down. This is normal. When we say that there is PAR-DT, that means to say that the T wave is opposite the direction of the R wave. So that, let's say that the QRS is going up, the T wave is going down. Or if the QRS complex is going down, the T wave goes up, and so on. So that's what PAR-DT mean to you. Okay, so one particular beat that we are bothered by is what's called a premature ventricular contraction. So let's define what a PVC or a premature ventricular contraction is. What does premature mean to you? You can have a premature baby, a premature withdrawal of your bank account, a premature conclusion. What does it mean? Something that you do before it's expected. So in this particular ECG, we have a pattern that is occurring regularly, and all of a sudden, the expected next finding should be here, but it occurs prematurely. This is what is called a premature beat. And notice, where is the direction of the QRS complex? Up or down?
Down.
And where's the direction of the T wave?
Up.
Up, This is what's called PAR-DT. So where is this coming from?
The ventricles.
The ventricles. Excellent. Because you remember wide QRS complex and PAR-DT. In addition to the PAR-DT, notice this QRS complex is so big or so wide compared to the normal QRS complex. All right. So PVCs are a natural occurrence. You might see a nice looking guy or an ugly guy pass by and you will develop a PVC. Well, that would be normal. However, PVCs need to be treated if they're going to be frequent. And when we say frequent, what does that mean? If they occur more than 10 per minute, in the presence of your diagnosis of a cardiac condition, such as a myocardial infarction, then it needs to be treated. Because if we allow this to continue, then what's going to happen? The patient will go RIP. Okay? So frequent PVCs are going to need to be treated. And so what is the treatment? Well, the treatment depends on the cause. And the reason for that is it could be caused by electrolyte abnormality, in particular potassium problems. If you have hypokalemia, for example, or hypomagnesemia, it could cause PVCs. Now, we treat them with agents that are anti-arrhythmic agents. So that would include amiodarone, lidocaine, as well as procainamide. So a low-dose beta blocker also is going to be the first-line drug in most cases. So these are the interventions for the treatment of PVCs. However, whenever you have 3 or more PVCs consecutively, consecutive meaning to say one after another, then that means to say it's now ventricular tachycardia. Question: are the QRS over here narrow or are they wide? Is it narrow or wide?
Wide.
No.
Wide.
Wide. Yeah.
Where is the direction of the QRS complex?
Down.
The
Down.
flexion.
Where's the direction of the T wave?
Up.
Up.
So
Yeah.
you have PAR-DT, correct? Wide
Yes.
QRS and PAR-DT. This is what is known as a ventricular beat. And because, what is the heart rate?
Mm,
What's the heart rate?
like 170 or something.
60.
So it's tachycardia, isn't it? So it's
Yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 160. Okay. So this is a tachycardia called ventricular tachycardia. So we need to treat this patient. All right. So what is the treatment of ventricular tachycardia? Well, amiodarone usually is given if the patient is going to be stable. And cardioversion is also going to be an option, particularly if the patient is unstable. Unstable means to say the patient has CASH. You remember CASH? What is C?
Chest pain.
A.
Wait.
Altered what?
Oh, LOC.
Yeah, mental status.
Mental
Okay.
status.
S.
Shortness of breath.
Shortness of breath.
And
full
what else?
shock,
And shock.
hypoxia,
Okay.
hypoxia,
And H.
hypoxia,
Hypotension.
hypertension, or hypertension.
Hypertension.
Or hypertension. Very good. Okay. So that is ventricular tachycardia. Notice that in this ventricular tachycardia, they're all uniform, isn't it? The complexes are all going down, correct? This is what
Yes.
is called monomorphic, meaning to say mono means one, morphic, it means shape. So this is what's called a monomorphic ventricular tachycardia. Okay, supposing I have monomorphic ventricular tachycardia and my blood pressure is 60 and I'm telling you, nurse, what are you going to do? What is the appropriate treatment?
Adenosine.
No, adenosine is only for narrow complex tachycardia. Could not be given for wide complex tachycardia. Okay. So what would you do? All right, the patient is barely saying, no, no. So this is stable or unstable? Is it
Very
stable or
unstable.
unstable? So what do we do?
Cardiogram.
Drugs or electricity?
Electricity.
Electricity,
Electricity.
very good.
Yeah.
Cardioversion or defibrillation?
Defib.
No,
No,
I
es
right?
cardiover,
I
cardiover.
told you, nurse. I'm
Cardiover,
so cardioversion. Okay.
I'm gonna
All
gonna
right.
kill him.
All right. So now there's another form of ventricular tachycardia, and this ventricular tachycardia is described in a French term, torsades de points. Now, I don't know if any of you speak French, but apparently the translation of torsades de point is of different heights or of different points. Now, when you're having a party, I don't know, I'm from the Philippines originally. So when we have parties, we usually decorate the room with this streamer. Do you do that?
Yes.
Yeah, okay. So imagine that, like a streamer, an ECG pattern wherein it looks like there's going to be small, and then there's going to be tall, and then there's going to be small, and then there's going to be tall. This is going to be torsades de point of different heights or of different points. So this form of tachycardia is usually termed torsades de point and usually is associated with hypomagnesemia, and therefore its treatment is entirely different. And in fact, patients who have torsades de point usually become unconscious right away. So notice over here, if I draw over here, is this a uniform monomorphic tachycardia or is it a polymorphic or torsades de point?
Look like a torsades point.
Torsades the point of different heights, right? Or of
Yeah.
different points or directions. So this is torsades the point. So the treatment of torsades the point is going to be that you're going to defibrillate the patient because the patient is RIP. Okay? All right, over here, what is an accurate interpretation of the ECG strip? This is going to be polymorphic ventricular tachycardia. In French, it's termed torsades de point. Okay. So
Okay.
the treatment is immediate defibrillation. Now there's another form of arrhythmia, which is a very bad form of arrhythmia. Can you identify a P wave?
No,
Can you identify a QRS?
no either.
Can you identify a T wave?
I don't know which one.
Okay. If you cannot identify anything, okay, then that means to say this is ventricular fibrillation. There's
Mhm.
no organization, there is no distinct waveforms that you identify. This is what is known as ventricular fibrillation. Ventricular fibrillation is equal to death. So you need to act immediately. In the event that this happens, what you're going to have to do is to attach the patient to the monitor. You're going to make sure that the patient is unresponsive. You're going to defibrillate at the highest energy that is available. Okay? So if it is unwitnessed, then you need to perform CPR for 5 cycles before you shock in order to give some oxygen to the heart so that it could be shocked better. And then, of course, you're going to establish an IV line and, of course, intubate when possible. And you continue CPR, and you will also give amiodarone or lidocaine and continue the same process over and over until the patient responds or comes back or is pronounced dead. The good thing about ventricular fibrillation is it is an easier cardiac arrest situation to deal with. Usually, or there's greater percentage, I should say, of these patients surviving compared to the next rhythm that we're going to talk about. And that is when there's nothing at all. And that is what is known as A, meaning to say absence of, systole means contraction. So the absence of contraction, or asystole, also known as ventricular standstill. This is the most difficult arrhythmia to interpret, right? Because it's a straight line. I'm just kidding. It should be the easiest one to identify. However, when you see a straight line on a patient, let me tell you a story. We had a nurse intern one time when I was still working in the ICU. And I had a nurse intern, and the ECG and the monitor on the nurse's station showed that there was a flat line. And so I said, Mark, could you please check on this patient to make sure that he's okay? He looks at the monitor and runs to the patient's room. And overheard was the patient was eating, and he says, Mr. Smith, you've got to stop eating now because we have to do CPR on you.
What?
While he's alive.
Because he assumed that the patient was in asystole. Well, it stands to reason, if you have common sense, that if the patient is talking to you, the flat line might be because he was disconnected from the monitor, right?
Yeah. Oh
You
my
would
God.
think so.
Yeah,
So
but
please
it
don't-
happens. Yeah, it happens.
Please don't commit that error. You are going to embarrass me. Okay? So always, when you see this happening, you need to check and assess the patient.
The leads. Yeah.
Okay? You need to assess the patient. If the patient is talking to you, it's not him. It is the machine. But if you go in there and there is nothing, then it is RIP. Then you mean to say that this is a standstill or a systole. So what then do you need to do? You need to make sure that you check the rhythm in 2 leads. Check responsiveness. And of course, you're going to start CPR, establish IV line, intubate when possible. And the only drug that will help is epinephrine. Whenever, by the way, you are in a cardiac arrest situation, and let's say you're still a nurse intern, you can show that you're smart by saying epinephrine 1 milligram. 5 minutes later, you're going to say epinephrine 1 milligram, because in any cardiac arrest situation, epinephrine 1 milligram needs to be given. So appear smart and always say epinephrine 1 milligram. You're going to say, your preceptor will say, oh, you're so smart. Obviously, because you were a student of Dr. Tom, right? Okay.
Of
So
course.
the other thing is to continue the CPR and the administration of epinephrine until the rhythm is resolved or the decision to stop the efforts are going to be given to you. Okay? When the doctor says, let's go ahead and stop, then that's when you would stop saying epinephrine 1 milligram. I would hate to see that the patient is now being wrapped for the morgue and you're saying epinephrine 1 milligram still. That would not be appropriate. Right?
Exactly. Yeah.
Okay. All right. The next thing that we're going to talk about are pacemakers. So pacemakers are electrical powered unit similar to this. It's very small, and I have a pacemaker right here. Okay. So actually, this in my hand is a pacemaker. It's very, very small. This one was from a patient that had the whole thing replaced. So I took it in order to use it for teaching. But anyway, it's very, very small, and it's implanted subcutaneously. And then there's a wire that now leads into the heart. Okay. There are several types of pacemakers, and they're basically going to be something like this. Okay. So before we go to the types of pacemakers, so let's say that this is the heart, and this is a wire that is connected to your pacemaker. Now, there are two parts of this cable that goes into the heart. One is going to deliver the electrical current. So this one is the pacing electrode. Pacing means to say that anytime the heart needs it, the pacemaker will discharge an electrical current and will now deliver the electrical current to the pacing electrode, and it will now electrocute, so to speak, the heart, and it will be stimulated to create an electrical impulse. So do you understand what a pacing electrode does? It is the one that delivers the electrical current. Now, however, you don't want to be delivering electrical current all the time. The computer or the pacemaker needs to know when it needs to deliver it. So there is another area of the pacemaker electrode, which is a sensor. It's called a sensing electrode. And this sensor will now detect when there is no electrical current. If the heart is not beating, it senses it and it tells the pacemaker, oh, the heart is not beating. So what should the pacemaker do? What should the pacemaker do?
It jumps in, like,
It delivers an electrical current. Okay.
Mhm.
So the sensor then is the one that's responsible for determining when an electrical current needs to be delivered.
Mm.
So you need to understand these two concepts, the pacing electrode and the sensing electrode.
Mhm.
Okay? All right. So pacemakers are actually classified according to the NBG code, meaning to say that there is an American Society of Pacing that says we're going to have this particular types of pacemakers, and I want everybody to use it the same way. So you have heard of a patient having a VVI pacemaker, for example, or maybe an AAI or D pacemaker or something like that. What does it mean? Okay, so the first letter of the alphabet right here, that is the chamber pace. Where is what part of the heart is being electrocuted? If it is going to be the ventricle, it's going to be the first letter of the code will be the V. If it is going to be the atrium, then it's going to be A. Or if it's going to be both, it's going to be D. Okay.
Mhm.
So I have a pacemaker, which is an AVI pacemaker. What is being electrocuted?
Mhm.
The first letter of the alphabet is A. So
So
what is
atrium.
the
Atrium.
atrium? Okay. I have a DDI pacemaker. What
Dual.
is being dual, both
Dual.
atria and the
And the
ventricle?
ventricle.
Understand? Okay.
Yes.
The second letter of the alphabet is going to be the chamber that sends. Did you understand that sensing electrode?
Yes.
So if I'm sensing the ventricle, that's the second letter. So in a VVI, What is being paced is the ventricle. What's being sensed is the ventricle.
Is the ventricle.
Okay, or it could be D, meaning to say both of them. All right. Now, there's two actions of a pacemaker. So when the sensor says that there is a beat, it could say, do not fire or fire to the pacemaker. If it says do not fire, then that means to say it's inhibited. If it says fire, then that means to say it is triggered. Or it could have a function of both. So in a AVI pacemaker, AVI, what is being electrocuted? Where is the
Atrium.
pacemaker being delivered?
Atrium.
The
Atrium.
atrium. What is being sensed?
The ventricle.
Okay. Every time it sees activity in the ventricles, what does the sensor command the pacemaker to do?
To contract toward the atrium.
No, I.
No?
I mean
Inhibit.
do not
Yeah.
fire.
Yes, that's right.
Okay. All right. So that's all I wanted to talk about the NBG code for pacemakers. Okay. Let's take a look.
Mm.
All right. Anytime you have a pacemaker fire, it's always going to deliver, and it will be seen in the electrocardiogram as a a vertical line is what I'm trying to look for. A vertical line that is going to indicate that the pacemaker has fired. So this is the only time that you will see in the electrocardiogram a straight vertical line. And if it is followed by a P wave, then that means to say that the atria is the one that's being paced. So we call this an atrial pacemaker. Now, if the spike occurs and there's going to be a QRS complex, then that means to say that the pacemaker is in the ventricles. The first letter is in the ventricles. And of course, if there's a spike before the P wave and a spike before the QRS complex, then when we have a dual pacemaker. Do you understand? All right.
Yeah.
Let's take that into perspective right over here. Do you see a straight vertical line? Do you know what a vertical line is? All right. See this? That's a straight vertical line. That means to say that there's a pacemaker. It's called a pacemaker spike. All right. So what type of pacemaker do we have? Atrial, ventricular, or is it dual? What follows the spike? It's easy. What follows the? Is it a P wave or QRS?
The QRS.
Yes.
So what is this then? If it's QRS follows the spike, what type of pacemaker is it? It's a ventricular pacemaker.
Yeah.
Okay? So this is a ventricular pacemaker. All right. Over here, do you see a spike?
Yes.
Where is the spike?
I see a spike before the P and also before the QRS.
So what is that?
A dual one.
Very good. A dual pacemaker. You're all so smart. I'm so proud of you. Okay, so we did not have a test. So the only way that I could do this is I'm going to now play Kahoot with you because I never played Kahoot with you. So let's go ahead and do that. Do you see the Kahoot game over here?
Okay.
Is it showing?
Not
And
yet.
not yet. It's loading.
Okay, let's go ahead and play Kahoot. and this would be the last part of the presentation.
No, we have to join. Oh, shoot. Where is it? Ah, got my phone. Have this on. No, I don't have my phone right now.
You don't have your phone? If you don't have your phone, that's fine. You can answer on the line, on the chat box. Okay, let's go ahead and get started then. If let me see, Dana, Dom, and Lanson. So Patricia and Obelius are not here.
Patricia,
Okay.
answer in the box,
Chat box.
on the chat box.
Okay, there she is. She was able to steal a phone.
For this ECG.
Okay, remember what you're seeing over here is the French arrhythmia of different heights or of different points. So this is a polymorphic ventricular tachycardia, and the treatment would be defibrillation. Okay, so the correct answer is letter B. Congratulations, Lanson. You are the fastest. All right, so let's go to the heart rate. What is the heart rate over here? What is our heart rate?
40?
40. So it's tachycardia or bradycardia?
Bradycardia.
Bradycardia. Okay, very good. So if it's bradycardia, would atropine work?
Yes.
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 Oh, yes.
Diltiazem is a calcium channel blocker. Will it work? What does calcium channel blocker do to heart rate?
It will slow down even more.
So this would not be appropriate. How about pacing? Would it help a patient with a heart rate of 40? Yes. And epinephrine, yes. So the correct answer is diltiazem or letter B. Congratulations to Lamson again. Yes, go ahead.
Yeah.
Okay, next. All right. So what we see in this ECG, the abnormality is that the ST segment is elevated. Did you see that? Here is the ST segment. It's elevated. So if that is elevated, the patient is most likely complaining of chest pain. Very good. All of you got that correctly. And as usual, Lanson was the fastest again. Let's go to number 4. Okay, everybody got that. I am so excited. The reason you got that is you saw P waves without any partners. And we said that anytime we have P waves without a partner, that means to say that there is an AV block. Congratulations to Lanson again and Dana, runner-up. Okay, I don't blame those of you who answered letter A. The correct answer is actually letter C, but letter A I will take. But what I'm trying to focus here is that there are PVCs. We know that this is PVC because it's wide. There's party T, but it occurs in a pattern. It's every third beat, and this is what is known as trigeminy. And they all look the same, and that is why we call this unifocal. It's not important as long as you identified the PVCs. Okay, so again, the fastest is Dana, and Lanson is the runner-up. And let's go to the next one.
Okay.
Okay, so let's take a look at the ECG first. This is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 190. This is narrow complex, so it's an SVT. And because the patient has cash, blood pressure of 80/60. You remember the hypotension, altered mental status. You remember the A in cash. So we need to electrical intervention, and that would be cardioversion. So let's see, it's equal between the four of you. Remember that if the patient is severely compromised, then we need to make sure that we terminate it immediately. Giving cardizem or beta blockers might be slower as far as its effect is concerned, and that's why cardioversion would be the best intervention. Congratulations to Dana again. All right. Okay. So if you answered letter C, it's incorrect. And the reason why it's incorrect is because the ST segment is elevated. Okay. And therefore, it is a sign of what? MI, ST elevation MI. Ischemia would be manifested by ST depression.
Depression.
Now, what I'm trying to emphasize over here is this PVC. Do you recognize that there's a PVC right over here?
Yeah.
It is a very dangerous type of PVC. It is when it's very close to the T wave. You remember that area that we don't want any electrical energy to be hitting, then it is a dangerous PVC. And that's why the correct answer is going to be letter A. Okay? And you said that this is a benign PVC. I don't blame you because I said, what would require treatment if it is very frequent? If it's frequent, meaning to say more than 10 PVCs in a minute in the presence of myocardial infarction or myocardial symptoms, then we would treat it. But in addition to that, if the PVCs are occurring very close to the T wave, we usually would treat it as well. Congratulations to Dana. Okay, so this is going to be a situation we're in. You cannot identify any waveforms at all. This is ventricular fibrillation. So what you need to do is to defibrillate, you remember, at the maximum dose. 25 joules. It's just like tapping somebody. So it will not cause any effect at all. So you need to have the maximum dose that would be 360 for a type of defibrillator called monophasic or 200 for a defibrillator called biphasic. So let's take a look who got that quickly. Dana again. Congratulations. Okay, so what we have over here is a sawtooth pattern. So you remember big teeth. Big teeth is what is known as atrial flutter. If the teeth is small, then that would be atrial fibrillation. So this is what is known as atrial flutter, which is control. That's not important to you. Okay. Congratulations to Dana. Okay, so let's discuss a T wave. The T wave should always be less than 1/2 of the R wave. So look at the height of the R wave right over here. 1/2 should be, the T wave should only be up to here, but it exceeds that. This means to say that this is a tall T wave. And what is the implication of a tall T wave? The implication of a tall T wave is that it is usually a manifestation of hyperkalemia. So you would see this in patients who are on dialysis, particularly if they have high or elevated potassium levels. Okay? So, oh, all of you got that correctly. Congratulations. All right. And next. Okay, so the ECG shows that there's atrial fibrillation. Notice this small teeth right here, and it's irregular. And the scenario says that sometimes the heart rate goes to 180. So it says, what could you do? And one of them is incorrect. Well, the thiazide could slow down the heart rate. Metoprolol or a beta blocker could also slow down the heart rate. And amiodarone, which is a antiarrhythmic agent, could also slow down the heart rate. So epinephrine will be contraindicated because the patient's rate sometimes goes to 180. Epinephrine will make it worse. Okay. And so congratulations to Dana again. Okay, so let's take a look at this. We have a line that is a vertical line, and it follows the QRS complex. So what kind of pacemaker is this? It's a ventricular pacemaker. Now, there are sometimes problems with a pacemaker wherein it does not cause the QRS complex, and therefore this is what is known as loss of capture. But the important thing here is you were able to identify what a ventricular pacemaker looks like. Okay, congratulations to Pat. Okay, so you should have noticed that there is nothing happening at all to this patient except for a P wave. So a patient cannot survive with just P wave alone. And because it's only P wave, it's called ventricular standstill, which is similar to asystole. Okay, in asystole, it's a flat line. In ventricular standstill, the ventricles are not working at all. So, oh, we already did that. Sorry. All right, congratulations, Dana. All right, you got it all. All of you got it. Okay, it's a wide QRS. It's rapid. It's 180, 170. So this is ventricular tachycardia. Excellent. All right, Dana again. Okay, so this is a slow rate. As you could see, there is a heart block, and therefore defibrillation would not be indicated. Cardioversion would not be indicated. Remember, defibrillation and cardioversion are for fast rates only. External pacing, dopamine is going to be okay. Adenosine is for SVT, and lidocaine is for ventricular tachycardia or ventricular fibrillation, and therefore that would not be appropriate. So C and D. Okay, so ladies and gentlemen, that ends my presentation. I want to ask you a favor. I actually need a evaluation from you. Actually, the reason why I'm doing this course is because nobody else wants to do it, and the dean twisted my arm to do it. And so I said, okay, I'll do it the last time. But anyway, I need an evaluation for me to be able to be reimbursed. So if you would be so kind to do the evaluation, I would greatly appreciate it. I also would like to hopefully request that you tell me if you have had any difficulties with the NCLEX, or let me know what happens to your test. I wish you luck and thank you for your participation.
Thank you
All
so
right.
much, Professor. It's
You're
really sad that you
welcome.
don't offer this often. I know it is extra, but it really was helpful just
Oh,
seeing
thank you.
really good information. And I'd learn better